اتفضلي.
Good afternoon. It's really my pleasure to participate in the second Egyptian International Conference. Today I'm going to speak about approach of peritoneal lesions. First, I would like to give a brief anatomy about the compartment of the peritoneal cavity. The peritoneum is a serous coat that protects and fixes the organs in places. We have parietal and visceral peritoneum. As shown in this image, the red line is the parietal peritoneum. It lines the surface of the wall of the anterior abdominal wall, then wraps laterally, then come to join at the posterior abdominal wall. While the visceral peritoneum lines the internal organ. Between these two spaces is the peritoneal cavity that's filled with the peritoneal fluid, which is the serous coat. How does the visceral peritoneum cover the organ? There are three ways the visceral peritoneum covers the organs. Organs in the abdomen are categorized based on how the visceral peritoneum covers them. We have intraperitoneal organs that are covered by visceral peritoneum from all different sides. And mesoperitoneal organs are covered from 3 different sides only, while the retroperitoneal organs covered from only one direction. The intraperitoneal organs are stomach, spleen, cecum, appendix, transverse and sigmoid colons, upper rectum, jejunum, and ileum. Mesoperitoneal organs are liver, gallbladder, ascending and descending colon, middle rectum, and urinary bladder when it is fully distended. But when it's empty, it will become a retroperitoneal organs. Duodenum, pancreas, kidneys, and suprarenal ureters are also retroperitoneal. What is the relation between both the visceral and parietal peritoneum? The parietal peritoneum continuous as the visceral through 4 ligaments: the coronary ligament, right and left triangular ligament, and the falciform ligament. The double layer of peritoneum that extends under the liver and above the lesser curvature of the stomach is the lesser omentum. As shown in this image, this is the lesser omentum under the surface of the liver and above this lesser curvature of the stomach. So the ligaments of the lesser omentum under the liver are 2. We have the hepatogastric and the hepatoduodenal. The fibrofatty tissue that extends from the greater curvature of the stomach to the transverse colon is the greater omentum. This yellow structure is the greater omentum, and this is the lesser omentum. It includes 3 ligaments. We have gastrophrenic and gastrosplenic and gastrocolic ligament. These 3 ligaments are a continuation of the hepatogastric ligament. So we can say that the hepatogastric ligament, which is part of the lesser omentum, is continuous on and covers the anterior and posterior surface of the stomach. So the greater omentum is initially forms from the hepatogastric ligament. This is the lesser omentum between the undersurface of the liver and the lesser curvature of the stomach, and this is the greater omentum, which covers the small intestine like an apron. 2 layers of visceral peritoneum that connect the intestine to the posterior abdominal wall is the mesentery. When all these mesentery meet at the posterior abdominal wall, they become the root of the mesentery, which starts at L2 vertebra. The peritoneal cavity is divided above and below the level of the transverse mesocolon. We have the supramesocolic space, the yellow compartment, and the inframesocolic space, which is the blue compartment. The supramesocolic space. We have first this right subphrenic space, while the left subphrenic space are 2 parts. This is the anterior and this is the posterior. The left subhepatic space is at the side of the lesser sac. We have right subhepatic space, one of them is anterior, and this is the posterior right subhepatic space. The inframesocolic space is divided into right mesocolic space, left mesocolic space, and this is right paracolic and left paracolic gutter. How to approach the peritoneal lesions? First, to reach the diagnosis, we have some questions that we have to answer. First, the location. Is the lesion intra or retroperitoneal? Then, the organ of origin, which is a big challenge. Then, the internal content. Is it solid or cystic lesion? First question is regarding the site of the lesion, is it intra versus retroperitoneal? We have to focus on the anterior pararenal space, which is the key in determining location. If displaced posteriorly, so it is intraperitoneal, and if displaced anteriorly, so it is retroperitoneal. This is the anterior pararenal space that we have to focus on. As we can show in this image, we have a very large cystic lesion. This lesion, we can demonstrate that the large bowel is displaced posteriorly, so this is an intraperitoneal structure. Yet in this image, the large bowel is displaced anteriorly, so it is a retroperitoneal structure. Organ of origin. Large tumors are often closely related to multiple organs, and it's so difficult to identify organ of origin. But some fine features may help us to detect the organ. First, the vascular supply, if we can see specific arterial supply supplying a definite organ and supplying the same lesion. If there is tissue pedicle connecting the lesion with the organ, or absence of organ. If we cannot identify the organ itself, so the lesion may be arising from that organ. Internal content. As we said before, the content of the lesion may be solid or cystic. The most common solid peritoneal lesion is to be metastasis or lymphoma. There is much less common lesions as listed here. But the most common cystic peritoneal lesion is mucinous carcinomatosis, abscess, pseudocyst, and there is much less common lesion. Cystic masses. When the organ of origin is obvious and the radiologist can focus on the organ-based differential diagnosis for the cystic mass. However, large cystic lesion arising from the peritoneal surface, omentum, mesentery, adnexa, or gastrointestinal tract is more challenging. Definite diagnosis is not always possible with imaging, yet careful assessment of the imaging appearance, location, relationship to adjacent structures can help to narrow these differential diagnoses. These are some of the criteria that we have to focus: multilocularity, wall thickness, internal septation, presence of enhancement, any solid internal components, or presence of calcifications. Cystic lesions arising from or within the peritoneum, mesentery, or GIT may be broadly grouped into true cyst, cystic neoplasm, and cystic appearing lesions, including inflammatory, infectious, and iatrogenic lesions. The true cysts are the typically benign appearing lesions. As on ultrasound, we can detect it as anechoic structure with posterior acoustic enhancement and no Doppler or no color on Doppler imaging. Presence of hemorrhage or any debris within the cyst may produce internal echoes. On CT, it will be well defined, homogeneous near water attenuation from 0 to 20 house field unit. On MRI, it will be of low signal on T1 and high signal on T2. Yet the presence of proteinous or hemorrhagic product in the cyst will decrease the T2 hyperintensity and increasing the T1 signal intensity. Differential diagnosis of simple cyst is the mesenteric cyst. But this is the term and is simply a descriptive of the location and the gross appearance of any cyst arising in the mesentery. So many entities are included under this terminology. First, the peritoneal simple mesothelial cyst, which is simple cyst present within the small bowel mesentery. Enteric duplication cyst related to the embryology. And non-pancreatic pseudocyst, it's secondary to surgery, trauma, infection. It is a sequelae of liquefaction of these structures incompletely and encased in thick fibrous tissue. Chyliolymphatic mesenteric cyst may show fat fluid level, and we can benefit from MRI, especially to detect the fat component from T1 out of phase or from the fat suppressed images. This is an image of peritoneal simple mesothelial cyst proved by the biopsy. On CT, it appears as unilocular thin-walled cyst present in the midline of the pelvic cavity with no evidence of septation or any solid component. So it is a simple cyst in the category of the mesenteric cyst proved by pathology to be peritoneal simple mesothelial cyst. This is a case of a chyliolymphatic mesenteric cyst. As shown in the CT, we can detect there is a fat density component within the cystic lesion, and there is evidence of fat fluid level that we can guide us to this diagnosis. On MRI, on T1 in phase, we see the fat component to be of hyperintense signal, and there is drop of this signal on the T1 out of phase. Multilocular cystic lesion. The first differential diagnosis will be the cystic lymphangioma, usually in pediatric age group. It's a small bowel mesentery. The content is usually chylous, but may be serous or hemorrhagic. As shown in this CT, we can see multilocular cystic lesion with fine internal septation present within the right paracolic gutter in pediatric age group, so it may be a cystic lymphangioma. Mucinous cystic neoplasm may show rim and septal calcification. The loculi can contain simple or proteinous fluid. Presence of solid or nodular component is rare, but if present, it should raise the concern for invasiveness. As shown in these axial and coronal cuts, we can see a very large cystic lesion with solid internal component, this raising the possibility to be malignancy. Peritoneal inclusion cyst. It is usually due to pelvic adhesion, secondary to surgery, trauma, endometriosis, or any pelvic inflammatory disease. As shown in this MRI, there is a big difference from MRI than CT. As in MRI, we can detect the internal septation very obviously. As shown in this image, there is a huge multilocular cystic lesion with multiple internal septation involving mainly the pelvic cavity in a known case of pelvic inflammatory disease, endometriosis, or post-surgery. So it is peritoneal inclusion cyst. Pseudomyxoma peritonei. It is not a pathologic entity, but rather a clinical or radiologic term, describing the finding of copious thick mucinous or gelatinous material on the peritoneal surface of the abdomen. It may exert mass effect on the solid organs, scalloping appearance along the liver or the spleen, and this allows differentiation from the simple ascites. As shown, this is very thick ascites, but scalloping of the contour of the liver raises the possibility to be pseudomyxoma peritonei than being a simple ascites. Peritoneal hydatid, it's often secondary to rupture of hydatid cyst in the liver or spleen, and less than 2% of patients can reflect primary peritoneal infection. On imaging, the hydatid appear as solitary unilocular lesion or multilocular with multiple daughter cyst, floating membrane, or internal debris. This is cystic lesion with multiple daughter cyst, so it is hydatid. Another hydatid lesion is seen here in the segment 6 of the liver. Solid peritoneal lesions. Peritoneal metastases are the most common peritoneal lesion. Gastrointestinal and ovarian cancers are the most common etiologies, and usually there are omental metastases in the form of omental cake with ascites. This is sheet of peritoneal thickening beneath the anterior abdominal wall. In most cases, it will be peritoneal carcinomatosis, but there is a big differential diagnosis, and we cannot always by imaging to detect the definite pathology, so always remember that the biopsy is the key role in differentiating between different types of solid peritoneal lesions. Lymphoma, non-Hodgkin, is the most common cause of lymphadenopathy. Usually there are other sites of lymphoma, and on CT, the lymph nodes will appear of homogeneous with minimal to no enhancement. Heterogeneous attenuation may be due to treatment or necrosis and fibrosis. Calcification also may occur. This is a globular soft tissue lesion, rather homogeneous, with no evidence of calcification, necrosis, or calcification. In a known patient of lymphoma, this raises the possibility to be lymphoma. Carcinoid. It is a slow-growing neuroendocrine tumor, most common found in the small bowel. Associated bowel wall thickening may occur due to a desmoplastic reaction and may show central calcification and may metastasize to the liver. This is a case where we can see a soft tissue lesion with a desmoplastic reaction and central calcific focus, and we can also hear the hepatic deposits, so this is a case of carcinoid. Extra gastrointestinal stromal tumors. These tumors appear as rounded soft tissue masses with endoluminal or exophytic growth. The mass of soft tissue density with central areas of necrosis may show peripheral enhancement due to the central necrosis, and here the calcification is uncommon. We can see this is a soft tissue lesion with central area of necrosis showing heterogeneous enhancement. It is a gastrointestinal stromal tumor proved by pathology. Inflammatory pseudotumor. It is a very rare condition occurring usually as a chronic inflammation, and it is usually diagnosed by exclusion, usually made at surgery or by biopsy. It is an occult infection due to minor trauma or post-surgical, may occur also in the lung, orbit, and mesentery. Mesenteric fibromatosis, which is desmoid. It is a well-circumscribed lesion with low density, may show some point of enhancement either within the lesion as some strands or around the lesion. The enhancement on MRI will be more intense compared to the enhancement on CT. Malignant mesothelioma, it is one of the primary peritoneal malignancies.
Professor Dina, you're end of time now.
Sorry?
Be careful. It's the end of time.
Okay.
End of the time.
It is the last
end of your time. Okay. You have how many?
Last slide.
You're almost?
Yes.
Okay, great.
It is one of the primary peritoneal malignancy, presents as a sheet-like peritoneal thickening with absence of lymphadenopathy associated with asbestos exposure. Take-home message. Cystic peritoneal masses are exceedingly rare and are commonly confused for ovarian neoplasm, pancreatic neoplasm. Clinically, they may be discovered incidentally at surgery or may present rarely as acute abdomen. The final diagnosis rests on the histopathological analysis. Not all solid lesions are malignant. However, the most common solid peritoneal lesions is metastasis. Thank you.